Thank you, Lara. It's a pleasure to be here. Gut involvement is quite common in patients with EDS, so I'm just going to tell you a little bit about my experience in this field for the last 10 years or so. We've been doing some research and trying to understand this, the pattern of gut involvement that occurs in our patients. So just to give you a little bit of an anatomical description of the gut. It's a long tube which starts really from the mouth down to the anus, and after the mouth you have the esophagus, also called the gullet, and after the esophagus at the lower end there is a valve which is called the gastroesophageal junction, where the esophagus meets the stomach. So when you swallow, this valve opens up, allows the food to go down into the stomach, and the stomach is like a mixer. It actually mixes the food, pretty much like the smoothie maker you have at home. It cuts the food particles into small pieces, and then the food then slowly passes down into the small bowel or the small intestine, where the digestion takes place. So this is where food is then, the nutrients that you need are absorbed, and the food that you don't need or the waste goes into the colon. And the colon is quite a large tube as well, and it's one of the reasons why it's so large is that it has to absorb all the water that is actually present in the waste that has gone into the colon. So the water is slowly absorbed as it makes progress around the colon, and then it reaches the lower end of the colon, which is called the rectum, and that's where you sense that you need to go to the toilet, and then you evacuate. Now, the gut has many layers in it, and if you look right from the middle part, again the laser doesn't quite work. So if you look at the circular, the target part there, that's the inner part. This is the lumen, as we call it. This is where the food resides, and all these finger-like projections are really part of the small intestine, where these finger-like projections help to recognize the nutrients that are present in our gut and help to absorb it. And then underneath that layer is a layer called the submucosa. This is where there is a rich plexus of nerves within it. There are various glands within it as well. And then you have two muscle layers. There's the inner circular muscle layer and then the outer longitudinal muscle layer. And between them there is another plexus of nerves. So there is a very, very rich nerve supply within the gut. And in fact, this nerve supply is as extensive as the number of nerves that are present in the spinal cord. And it's often described as the little brain of the body, and it connects with the big brain as well through the nerves that pass between the gut and the brain. If you take a cross-section of this and look at it more carefully to see where the collagen is, we see that there are fibers of connective tissue which travel all the way in the longitudinal muscle, which is the outer muscle, down towards the middle part, which is where the nerves are. And around where the nerves are, you can actually see it labeled myenteric plexus. This is where the main nerves are. And around the myenteric plexus, you can see that there are a lot of collagen and elastin fibers. So the gut has a rich, in its structure, a lot of connective tissue, and collagen and elastin fibers appear to be quite common, and they seem to be also localized around the nerves in the gut as well. So potentially one can imagine that if there is a problem with this collagen, then the gut nervous system and the muscles may malfunction, and there may be problems in how the gut then moves or senses. The idea that gut symptoms are present in patients with Ehlers-Danlos syndrome was first described by Professor Graham and Dr. Hakim in this paper published in 2004, where they described that the range of symptoms that patients with joint hypermobility syndrome, which would now be a combination of hypermobile EDS and hypermobile spectrum disorder, the range of symptoms that they experience. And as you can see, as I've highlighted, that joint hypermobility syndrome patients complain of a lot more gastrointestinal symptoms, along with all the other symptoms as well, compared to healthy controls. But since then, there's a lot more work that has been done, and this is a summary slide from all the data that had been published until 2017, which demonstrates the range of symptoms that have been associated in patients with hypermobile EDS and HSD. And as you can see, the whole range of symptoms that you could imagine that could occur in the gastrointestinal tract are present. However, there are some that are particularly more common. Nausea appears to be a very common symptom in our patients. Anywhere between 32 to 71% can complain of that. Heartburn, which is like burning discomfort that occurs sometimes due to acid coming up from the stomach into the esophagus. That is quite common as well. Bloating is very common in our clinical experience as well. We see a lot of bloating in the tummy. And dyspepsia, which is indigestion, and there are two types of indigestion. One which is associated with a lot of pain, called epigastric pain. That is very common, almost 80%. Whereas postprandial fullness, which is fullness after a meal, is also very common. These are the two different types of indigestion which is recognized in the international literature. Those two are very, very common in our experience in the patients that we see. And abdominal pain is the most common symptom. Anywhere between 50 to 100% of patients complain of abdominal pain in the series that present to us in our clinics. And amongst the bowel problems, alternating bowel habit appears to be the most common. So people may have constipation for a period of time, and then they may get diarrhea, and then the constipation will start again, and then they will, this pattern seems to continue. There is a recent paper that has actually been published just really a few weeks ago, where they compare the prevalence of symptoms and diagnosis in patients with hypermobile EDS versus all other types of EDS as well. And as you can see, pretty much there is no difference in the type of symptoms that are present in those with the hypermobile type versus the non-hypermobile type, which will include the vascular, the classic, and so on. And just to point out that patients, there is a lot of irritable bowel syndrome there, about 58% and 55% respectively in the hypermobile and non-hypermobile, and the other EDS subtypes complain of irritable bowel syndrome. Dyspepsia, which again, as I said, is indigestion, again is very common, about 55% in both groups present with indigestion type of symptoms. And I think it's interesting that this is something that we're picking up in our clinics as well, that we see cyclical vomiting as a symptom as well that our patients present with. These are patients who will have bouts of vomiting, and then it settles down and they have completely vomiting-free periods that may last for a few weeks, for a few months, and then they will have another cycle of vomiting. So something described as cyclical vomiting, often associated with migraines as well. And we're beginning to see much more of that now. So when we look at the gut problems and think about, if we can categorize them into different categories, and I think I would categorize them more into mechanical problems, sensitivity problems, and problems that could be associated with a leaky gut. And all of these can occur in the same patient. You may have patients predominantly one type of problem or the other type, but there are some who have all of these problems as well. Looking at the mechanical problems in the gut, I often give this example that you open the tap in your kitchen and the water pours out because there's a metal pipe bringing the water to the tap. However, if it was a rubber pipe, your hose pipe, which is made of rubber, the water doesn't come out as fast as it should. And this is a natural law of physics, that flow in a tube is better if the tube is more rigid. And if you have a problem where the muscles and the nerves in the gut are not functioning properly, as we've said that there is a link between connective tissue and the muscles and the nerves, and if there is an effect on the muscles and nerves in the gut, then it is possible, and also if the collagen is more elastic and stretchy, and it is possible that this gut will be slow and movements will be generally slow. And while one would imagine that the gut may be a bit more elastic and stretchy in patients, and we certainly see that in the lower end of the gut, in the rectum, because we see that the rectum is sometimes quite ballooned and bigger in diameter than normal. And there is a small subgroup of patients where we see a distended bowel as well, small or large bowel. But that is not universal. Vast majority of patients do not have a distended bowel. It appears that there are defects in movement, but not necessarily a distended bowel. It is possible that even though it is not larger than it should be, it is more stretchy and elastic. And certainly when we do camera tests like colonoscopies, the colonoscopists often say that this is a long, tortuous, quite a winding bowel, and that seems to be reported more anecdotally in patients with EDS. As I said, acid, heartburn, reflux type of symptoms are again very common in our patients, and this may be due to a combination of factors. The esophagus itself may be weak, it's not actually pushing things down properly, the stomach may be slow, and that combination may then cause the acid to actually come up into the esophagus because it's staying in the stomach for longer, and the valve at the lower end of the esophagus may be weak. The movements in the esophagus may be weak, so that acid, when it comes up, doesn't go down as quickly as it should do, and therefore you get more symptoms. And usually, we don't see inflammation in the esophagus. We see a lot of symptoms related to reflux, but usually it is not an inflamed, ulcerated esophagus. We also see swallowing difficulty as well. And there is a proportion of patients who feel as if food is getting stuck in their esophagus as they swallow. And that appears to be because swallowing requires when you swallow the food, it requires the esophagus to make contractions. These are milking waves that it milks the food down from the back of the throat down into the stomach. And we've done studies which actually show that in a lot of our patients with hypermobile type of EDS particularly, the movements of the esophagus can be a bit weak. And that can then cause difficulty with swallowing and feeling that food is actually sticking in the gut. We've talked about the fact that these disorders such as dyspepsia or indigestion, often described as functional gastrointestinal disorders, because in the past largely a cause for these conditions has not really been known. So we see patients with a lot of burning discomfort in the upper part of the tummy, or pain when they eat in the upper part of the tummy, or bloating or distension, and this is what is described as functional dyspepsia. Nausea and vomiting can be quite common as well. A feeling of tightness around the abdomen, as if there is a band around the abdomen, is sometimes described. And bloating is a very common symptom that we see in our patients. Bloating can be described more of a feeling of fullness after a meal, and it can also be described as a distension of the abdomen. And we as physicians, we have to make that distinction. Sometimes patients describe both. They feel full and the tummy is distended, but at other times they predominantly talk about fullness or the distension that can actually occur. Now, this sort of indigestion could be associated with problems with emptying of the stomach as well in some of our patients. And we see both slow emptying of the stomach and rapid emptying of the stomach. So the stomach, as I said, is a mixer. It mixes the food, breaks it down into small particles. The acid in the stomach kills off the bacteria. The juices help to soften the stool and do some pre-digestion. And then it slowly, from the stomach, the contents move down into the duodenum, which is the upper part of the small bowel. And you can have problems with both. If the stomach is not emptying properly, you'll feel more full after a meal. You may experience nausea. You may experience sometimes vomiting as well. But if the stomach is emptying very rapidly into the small bowel, that can also cause a feeling of fullness, because the small bowel is actually a much narrower tube. The duodenum, as you can see, is much narrower tube than the stomach. And if food is actually going down very quickly, that will also cause discomfort, may cause pain, may cause a feeling of bloating, distension, nausea, etc. as well. And it can be very difficult to distinguish unless you do the right test, who's got a rapidly moving stomach, who's got a slowly moving stomach. Constipation, as I say, is a common problem in our patients. Excuse me. And what this X-ray shows is that the excuse me, the patient has been given some radiopaque markers which are visible on an X-ray. So these are just capsules that you swallow, and then you follow them over a period of 5 days to see where they've got to. This is an X-ray taken actually on day 5. By day 5, you should have cleared everything out. And as you can see, could I have some water, please? There. Okay. So by day 5, everything should have cleared, but here you see that all the markers are present in the colon, and most of them appear to be in the left side of the colon. And the vast majority of the mouth, it seems on the right, but that's the way that the X-rays are shown. That's the colon on the right side of your picture is actually the left part of the colon. Most of them are actually localized in the pelvis. So it appears that the patient is having difficulty in evacuating. And we see that sometimes, that the transit is altogether completely normal, that the markers will get into the pelvis, into the rectum, but then there is difficulty in evacuation. And that could be due to a number of problems. There's the pelvic floor is not moving incredibly well. Pelvic floor is sluggish. And in addition, there can be a problem in the rectum, that the rectum itself, when it tries to squeeze, instead of squeezing it out, it sort of flops down on itself. And you can sometimes find a pocket there called a rectocele, that stool sort of gets trapped into that pocket. Excuse me. And as I can see over here, that you've got the rectum, and what you're seeing here below is a pocket that is formed here. And the stool is then getting trapped into that pocket. So you go to the toilet and you actually pass a little bit of stool, but you don't feel empty because the stool has gone into that pocket. And the more you strain, nothing really happens because of the trapped stool over there. And eventually that stool will come out, and then you feel that you need to go again, and you can, and the patients can try and empty. And repeated straining then also can cause hemorrhoids, and the straining can also cause the rectum, because the rectum, if it's a bit more elastic and stretchy, it can flop down, something which we call intussusception, as the pressure is exerted to try and empty. Now, I often describe this as an analogy. I tend to see that in patients with quite severe constipation, they often have a lot of cramping, abdominal pain, bloating, and sometimes they actually get these oily stools that float on the water, difficult to flush, quite smelly. And I think that is because of the stagnation of the stool. If you're not emptying, your bowel is like a river. It's a tube, and I give the analogy that it should actually empty and flow like a river. Okay. However, if it is not flowing like a river and it becomes a pond, okay, so you're not going to drink water. If you're lost in a forest, you're not going to drink water from a pond because stagnant water is dirty, it's got bacteria in it. And these bacteria, the gut has millions of bacteria normally. These are part of a healthy ecosystem. They help us to digest the food, they help to regulate the immune system. And if these bacteria become unhealthy, then the gut becomes unhealthy. You can get low-grade inflammation developing in the gut. Then these bacteria start to ferment your food, and especially carbohydrates, and especially complex carbohydrates, refined sugars, often described as for the FODMAPs, more fermentable type of carbohydrates. And that will then produce quite a lot of bloating, discomfort, pain, etc. that can actually get. And it can be quite rewarding to actually treat this bacterial overgrowth as well. But the important thing is to try and restore the function. No matter how many times you try and treat this bacterial overgrowth in somebody who's constipated, this will come back, because until and unless the gut starts to move again and clear itself and flows like a river, it is not going to, the bacteria are not going to normalize. Then we talk about the sensitive gut. Okay, so the gut is also in some patients very, very sensitive. A small amount of food may cause quite a lot of pain in some of our patients. And we think that there are 2 or 3 mechanisms that are operating here. The gut itself may have become sensitive, so what we call peripheral sensitization, that that it could be some of our patients may have had some inflammation in the gut, may have had an infection like a gastroenteritis, and that triggers a sensitivity. And just like in the peripheral nerves, our patients tend to appear to be more prone to pain in the limbs, etc. The nerves seem to get sensitized more easily. In the same way, the gut nerves, after some sort of injury, inflammation in the gut, they become more sensitized. But then they also, if the injury or inflammation is strong enough, that leads to sensitization at the level of the spinal cord. This is called central sensitization. Now, the original inflammation or injury may heal, but if the spinal nerves become sensitized, then they can remain sensitized for a very long time. So when you do a camera test, the gut looks absolutely healthy. But the nerves there remain sensitized because the sensitization is now moved into the spinal cord. And this type of sensitization can last for quite a long time, and it can cause quite a lot of pain and discomfort. And then, of course, all pain is perceived at the level of the brain. Okay? So certain parts of the brain get activated when a pain signal arrives there, and that's why you sense the pain. But when you have stress or anxiety, then the perception of pain can be intensified. And there are pathways that go from the brain down to the spinal cord where the pain nerves come in, and they usually help to dampen down the pain. And this reduction in pain by this descending pathway is diminished at times of stress. So the same pain may feel a lot more because the inhibition is not there anymore. And therefore, when we actually look at pain management, we have to think about what is happening in the gut, so the sensitivity of the nerves in the gut, which can lead to increased pain perception, but also whether anxiety, depression, etc. are contributing to the increased perception of pain. So it has to be a multidisciplinary method of actually managing it. Now, I just want to talk about another cause of pain that I'm seeing a lot more in my patients, which is pain coming from the muscles of the tummy wall. Okay, so not coming from the organs, but from the muscles of the tummy wall, and sometimes related to trapped nerves in these muscles on the tummy wall. As you can see, there are lots of muscles on the tummy wall, and the big muscle in the middle, right in the middle, extending for about 5 or 6 centimeters on either side, is called the rectus muscle. This is the muscle that people go to the gym and try and get this six-pack, we get definition of this muscle through exercise. And this muscle has a lot of nerves that come through it. There's a nerve that comes through on either side of this muscle every 5 or 6 centimeters. That you can actually see those sort of white bits that are coming through the muscle are the nerves that are coming through. And they go through these are called anterior cutaneous nerves, and they go through a canal in the muscle. So the silver cord that's coming through, that's the nerve. It goes through a canal in the muscle and then comes out and turns at right angle. And you can get a trapped nerve in this canal, just like you can get something as described as a carpal tunnel where the median nerve gets trapped in the wrist, and that causes a lot of burning discomfort in the hand and so on. So similarly, you can get a trapped nerve in the muscles of the tummy wall as well. And because in our patients, often the core strength is not good, posture is not good, you may have some scoliosis, etc., that leads to the use of abdominal wall muscles quite a lot. And that repetitive strain on the abdominal wall then leads to trigger points that you develop a lot of sort of myofascial type of trigger points there, but you can also develop these trapped nerves. And these can be treated through good physiotherapy, trigger point release, exercise, and also sometimes we can inject these trigger points with local anesthetic and steroid, and that helps to reduce it. So this is often confused as a tummy pain, and this sort of pain is actually present 24/7. You have it all the time. Pain coming from the organs in the gut is usually not present 24/7. It comes and goes. It's worse after meals, particularly worse when you try and open your bowels, etc. But this pain, you wake up with it, you go to sleep with it, and movement makes it worse. If you turn left, it's worse, or right, it's worse. You lie back, it may be a bit better, or may even make it worse as your tummy stretches more. So there's a postural element to it. You bend down to pick something up, it actually hurts. If you have that sort of pain, then you may have abdominal wall pain. And I think this needs to be thought about and discussed with your physicians. And then coming to leaky gut, and I have to say that there is no strong evidence that gut in patients with EDS is leaky. But this is a hypothesis. This is based on current understanding of the literature. I feel that is likely to be a factor in some of the patients that we see. The intestine has a number of cells. These are the building blocks of the entire body. Okay? And these cells are very tightly bound together to one another. There are very few gaps between the cells. That prevents unwanted food particles, bacteria, drugs, etc., to get through into the lining of the gut. However, if there has been quite a lot of inflammation, if the bacteria have been unhealthy in the gut, even stress can do that as well. There's lots of experimental evidence that stress can cause the gut to become leaky. For a variety of reasons, the gaps between the cells, they can open up. And that then allows unregulated food particles to get through. Normally, the immune system signals to the gut to actually say that you can take this in and you shouldn't take this particular type of food particle. But now things are getting through unregulated, and that will cause an overactivity of the immune system, which can then trigger a lot of intolerances to food because the immune system reacts to foods and other particles that are coming through, etc. And that can be the reason for food allergies and intolerances that can develop in our patients. And we also talked about histamine and histamine activation and mast cell activation and so on. And again, strong concrete evidence is not yet available, but certainly some of our patients present with a lot of allergies and they develop food-related symptoms which are like an allergy-related symptom. Quite often in a lot of patients, the intolerance is not related to this. There are other factors that cause intolerance like carbohydrate intolerance and lactose intolerance and various other things. Mast cell is a very specific condition which is really present in only, so far in our experience, a small percentage of patients, and very difficult to clinically diagnose. But patients can get quite a lot of, and this is immediately after meals, cramps, diarrhea, a lot of gas, etc. Now, POTS is also associated with tummy symptoms, and we see that the gut has a very rich supply of blood vessels. And when we eat, blood supply to the tummy increases. Okay? And that increase in blood supply in somebody who's running with low blood pressure could then trigger symptoms because the blood is now drained off into the tummy cavity and the blood pressure may fall and the pulse rate might go up, and that may produce symptoms of lightheadedness, faintness, feeling of fainting, and some people feel very drowsy, they have to lie down after a meal and so on. And there is also this what is described as dumping syndrome or dumping hypothesis, that the stomach normally has got different parts and these different parts work together to try and mix the food together, and then it slowly empties. The valve at the lower end of the stomach opens up and the food starts to slowly empty. And usually a liquid meal will empty much faster than a solid meal. And the gut, as I said, has a lot of blood vessels around it, and the duodenum, the first part, has also got a lot of blood vessels around it. And if you eat a food which is very rich in carbohydrates, a lot of sugars, etc., and it's going down and you have rapid stomach emptying and it's predominantly a liquid meal that you've had, and it goes down from the stomach into the small bowel very quickly, then the concentration of that fluid becomes very high in the small bowel. And if you remember your physics, your science lessons, there's something called osmosis, whereas that if you actually have a beaker and divide that into two sections and you have a semi-permeable membrane, and you have a high concentration fluid on one side and a low concentration on the other side, then fluid will move from low concentration to high concentration to now normalize it. So in the same way, if you've got high concentration of food in the small bowel, then the plasma from the blood vessels will move from the blood vessels into the tummy cavity to try and neutralize, and you get a drop in blood pressure and you get an increase in heart rate. So this is what is described as the dumping syndrome, that if you've had a big sort of high sugar, high carbohydrate meal and it just dumps down into the esophagus, usually occurs within 15 to 30 minutes of eating, you can get this sort of feeling of cramping, dizziness, etc., just because there is a shift of fluid now from the blood vessels into the tummy cavity. Coming to management, I think it's important for our patients to acknowledge that there could be a problem related to the diagnosis of EDS, and that can have an effect on gastrointestinal symptoms. Just explaining what we know about this association can be helpful, and it helps them to recognize that there is an association between all the other symptoms that they've got in the body and the tummy symptoms. These are not all independent, but all part of the same problem. And we like to say that we need a multidisciplinary approach with different colleagues working together, dietitians, pain management, patients who understand, colleagues who understand how to treat POTS, joint problems, urinary involvement, psychologists, all need to work together, really, to try and help the patients that we see. And one of the first things that we need to really make sure is to exclude other problems, because just like any patient with tummy problems can have a range of reasons for developing the symptoms, we need to exclude things like inflammatory bowel disease, celiac disease, and other autoimmune connective tissue disorders that can also affect the gut. And there is some evidence in the literature that these things are more common in a hypermobile EDS, but that's really very preliminary data. And we can run some tests on physiology, because the endoscopies and ultrasound and so on can all be negative. But you can do studies which look at movement of the gut, look at sensitivity of the gut, like stomach emptying study. You can do hydrogen methane breath tests to see whether people have a bacterial overgrowth or not, transit studies and physiology studies on the pelvic floor, etc., that help to define the problem in terms of movement and sensation, etc. A lot of patients describe food intolerance, and there is not a lot of evidence as to what diet is best for the patient, but certainly now there is some evidence, as I'll show you in the next slide, that the low FODMAP diet, which is low in fermentable carbohydrates, can help some patients with bloating, pain, discomfort, etc. The low histamine diet has been suggested in people with more mast cell type or histamine sensitivity type of problems, but again, the evidence for that is lacking in our patient. There are no controlled clinical trials that have been done to look at the effect of the low histamine diet. And certainly in some patients where there appears to be a lot of allergies and allergy-related symptoms after meals, and antihistamines and mast cell stabilizers can be helpful, sodium chromoglycate and ketotifen and so on. These type of medicine can be considered in those where there appears to be a mast cell-related problem. And this is just a study just very recently published, which suggests that if you use a FODMAP diet, then pain, bloating, constipation, diarrhea, etc., can improve in patients with hypermobile EDS. In patients with POTS, it's generally, we advise that if you're getting dumping syndrome, then eat slowly, don't mix liquids with solids, increase the fat and protein content in your diet, lie down for 30 minutes while you eat, increase your salt intake, and don't eat very sugary foods or very high carbohydrates. And there are some medicines that are used in POTS generally, like flutocortisone, midodrine, and sometimes octreotide, which is a hormone which can increase the contraction of the blood vessels in the tummy cavity. That can help. Enteral and parenteral direct feeding into the gut and into the venous system, what's called as TPN often. That's required in a very, very small percentage of patients, but the failure rate is high due to infections, pain, etc. at the site and so on. And we need to consider how we can improve these patients before they get to that stage and look at whether they may have POTS or mast cell or abdominal wall pain or bacterial overgrowth. And sometimes you can rescue patients by looking at those patients. And psychological issues need to be looked at, and there's a very small proportion of patients we're beginning to see where there is some overlap with either disordered eating or eating disorder, and we need to look into all of those aspects as well. And I think the general principle is to avoid strong painkillers like opioids, because morphine and all the other derivatives like that, because they actually slow the gut down and make all the symptoms actually worse. And long term, they're not really a solution. And pain medicines like gabapentin, amitriptyline, etc., that help to calm the nerves down, they can be helpful. But psychological approaches like cognitive behavioral therapy, hypnotherapy, deep breathing, SSRIs, etc., these are also helpful in pain management. For treatment of constipation, softening the stools with Movicol or stimulating with medicines like Senecot, Dulcolax, and there are some prokinetics which stimulate the gut quite strongly called Resolor. They can be helpful in managing constipation. And suppositories, sometimes we have a lot of evacuatory difficulty, then suppositories can be used. Probiotics, there's no strong evidence, but in those with a lot of bacterial overgrowth, probiotics can be considered along with low FODMAP diet. And sometimes we use antibiotics in patients with quite significant bacterial overgrowth. Rifaximin is a commonly one. But just to summarize that we really do need multidisciplinary care in our patients because there's so many different symptoms, and we need commissioned services to help manage our patients. And just to acknowledge colleagues who've been involved and our various funders as well. Thank you very much. Sorry.
Okay, so I'm going to jump straight into it. Is it common to have gallbladder problems in EDS patients, and if so, why?
Just like there can be motility, movement problems in the entire gut, potentially it is possible that the gallbladder may be slow, but there is no direct link that has been established between gallstones or movement disorders of the gallbladder and EDS at the moment. There's no direct link that has been demonstrated in all the studies that have been done so far.
Is it common in EDS patients that the large intestines or other digestive organs have moved, falling down, or are differently situated than normal?
Yes, so there's a condition called visceroptosis where you actually have all the organs hanging much lower down in the abdominal cavity than normal. That's because the ligaments are very lax and they allow the organs to actually drop down. So that can happen in the colon as well, that it can be. And also we see it in the pelvic floor. The pelvic floor can be very mobile, and that can lead to sometimes difficulty in evacuation, and sometimes you see prolapse of the rectum. We see pelvic organ prolapse as well in our patients. So there's a whole range of those sorts of problems can occur, but relatively uncommon, but we do see them.
What is your opinion on the use of PPIs to manage reflux and heartburn in EDS, and do they result in a compensatory increase in acid production long term?
Very good question. In severe heartburn, where other management approaches are not helping, particularly dietary approaches to actually reduce the type of foods that are producing these symptoms, and looking at situations where stomach emptying may be very slow and that's provoking it. So treatment of delayed stomach emptying can also help to reduce heartburn, but sometimes we do have to use proton pump inhibitors. But long-term proton pump inhibitors can have problems which can increase even bacterial overgrowth because you need acid to kill off the bacteria and so on. And a range of other problems like iron deficiency and so on. And if you stop the proton pump inhibitors suddenly, then you get rebound reflux. So suddenly the acid secretion increases. So if you're going to come off the proton pump inhibitors, come off them slowly over a few weeks rather than stopping them suddenly. Ranitidine or other H2 antagonists can also be used, and they have a more gentle effect in mild to moderate reflux symptoms. Ranitidine or cimetidine, which are histamine 2 blockers, can be effective, and they can also be effective in people with allergies as well.
Thank you. Can the gut issues you talked about result in celiac-like villi damage?
No, not directly. These gut issues do not cause celiac-like damage, but there are 2 reports which suggest that celiac disease is more common in hypermobile EDS patients compared to the general population. And so we're following up on that. There is a study that we are just about to start on that particular topic, but there is some evidence that there could be a higher incidence of celiac.
In terms of nutrition, what kind of supplements like vitamins, magnesium, zinc, etc. could improve symptoms?
Again, there is no clear bona fide guidance on that. And I think if your nutrition overall is poor, you need to improve your nutrient intake, and a whole range of vitamins and minerals may be necessary. And some people have advocated the use of magnesium, and our patients sometimes do find that useful as well. But I think this is something that needs to be discussed with your nutrition specialist and your dietitians, etc., to try and achieve as balanced a diet as possible. And if that's not possible, nutrient supplements may be required, and that will vary between individuals as to what the nutrient supplements would be.
Can symptoms of swallowing problems be intermittent?
Yes.
Okay.
They can be, yeah.
Is there a reason behind cyclical vomiting and any explanation as to why it's common alongside periods of migraines? And are there any treatments?
Yes, so it's certainly more common in patients with migraine. And this group that I see is migraines, allergies, food-related problems in the gastrointestinal tract, and then cyclical vomiting. And I think there is probably a common factor within all of that which could be related to histamine and mast cell activation, but it remains unproven. But in some of these patients with cyclical vomiting, when we try antihistamines and mast cell stabilizers, they improve. Ketotifen is actually used in the treatment of both migraine and cyclical vomiting, and that's a mast cell stabilizer. There's actually recognized that this can help. So certainly there seems to be some commonality there related to histamine and mast cell, but this remains to be proven. In migraine, certainly it's been recognized that histamine can be an issue in a proportion of patients with migraine.
Do you know of any clinical trials or research collecting data on links between the gut issues and EDS?
Yes, there's lots of studies that are going on around the world on gut issues and EDS, and people are, I think the association between gut symptoms and EDS is now reasonably well established. Now it's the issue of identifying whether one causes the other. There's a little difference in that association does not mean causation, and I think the next phase has to be what causes these symptoms, and where the problem is, whether it's in the muscles, in the nerves, in the connective tissue, how they interact with one another. That needs to be understood a lot better.
Fantastic. And we're so lucky that Professor Aziz is here today because he really is steering this research globally. So thank you very much for all the work you're doing in this area and for being here today. Thank you.
Thank you.